Thank you, Professor Taggart. Ladies and gentlemen, I apologize by necessity. My slides will repeat some of the statements which Professor Taggart made before. Some of them will be even more critical than his were. So one, without trying to appear against progress and being anti-intellectual, I can tell you that the modern guidelines are all based on prospective randomized studies, and they are supposed to be absolutely best. And then you have these classes of recommendation, and in green you will always see in these guidelines, this is the class 1, that the given treatment is beneficial and we can accept 2A also. But when you look at the level of evidence A is multiple randomized trial on meta-analysis. This usually there is no level of evidence A when some kind of guidelines are quoted, or very few. This is what the science considers to be the pyramid of knowledge. Randomized, controlled, and double-blind studies are level A. Double-blind studies are not possible in surgery. You cannot hide from the patient the fact that you performed a stenotomy or you performed surgery. And it's also difficult to do it double-blind even with a treating physician. So we are maximum at level B and very often at level C. All randomized studies, and this is the major problem, are derived from a minuscule portion of the actual clinical load. Very small part goes in. And the meta-analysis paper, which are now very popular because so many statisticians are parts of the team, the authors who write these meta-analysis papers, they have absolutely no control about the quality of data which is entering in their analysis, and they all have to accept the results as they are presented. And then you will have this analysis of the meta-analysis. One has to know to read how it is. I don't know how many of you are really aware of the statistic, but reading odds ratio, which is really a percentage of likelihood, and then you will have a line of identity in the middle. Here, this is the line of identity, the equal treatment in both sides, and then you will have a box, and the size of the box is usually reflects the size of the sample. The confidence limits are shown here, and diamonds are aggregate results when you take 3 or 4 studies together, and usually here line confidence limits, and in the end, in the red, are the summary of the data. Not easy to read. I have taken time some number of years ago when the first studies came between medical treatment and surgical treatment of coronary artery disease. These are the RITA, ERATI, GABI, EAST trial, CABRI, BARI trial. I looked at the total material. Out of 91,000 patients which were screened, only 4.9% of the patients entered these trials. So you can see how representative they are. We were participating at the University of Zurich in the ARTS trial. This was before your ART trial. Okay, ARTS trial was about 15 years before. And in the time when we were randomizing the patient, we were randomizing her for coronary artery bypass grafting and PTCA. In this period, we randomized, not we randomized, cardiologists decided that 0.5% of this material is suitable for randomization. The rest was straightforward, either to surgery or to PTCA. And speaking as a skeptic, usually the surgeon will ask why some obvious fact must be supported by prospective randomized study. For instance, that the coronary artery bypass graft increases the flow to myocardium and the aortic valve replacement eliminates the gradient. A couple of years ago, this paper was published in a British medical journal. It is published around Christmas time, where they usually have a scientific article which appears as a joke. And this was about by the 2 scientists that use of parachute to prevent death and major trauma related to gravitational challenge. Systematic review of randomized controlled trials. They went through the literature, trying to find out if there are randomized control trials if you need a parachute when you jump out of the aeroplane, or you can do without. And they have found some people who survived fall from the aeroplane without use of parachute. They have found some papers describing very heavy injury of the people which used parachute, and they came to the conclusion that our search strategy, in spite of using the statistical approach with the most modern art, strategy did not find any randomized controlled study of the parachute. So the use of parachute, according to them, is not has not been proven, or everybody uses. And the final sentence of this paper, I have to quote it here: individuals who insist that all intervention need to be validated by randomized controlled trial need to come down to earth with a bump. The second problem with the randomized controlled studies, which approaches the one which we discussed with Professor Taggart, patients recruited for randomized controlled trials have usually, not always, better survival and better results than those which have been eliminated from the trial because some exclusion criteria. Example, use of nifedipine in acute myocardial infarction was so-called trend trial. They found in the group with placebo and with the nifedipine, they found basically no difference both in mortality and both with the patients in acute myocardial infarction. But when you look at the mortality of the patients which were excluded from the trial, it was about 3 times higher. So obviously there was some selection taking place before the trial started. It has been shown by this beautiful paper, which I always quote. It is an old paper, many of you have not seen it. It's in a circulation in the 80s. Kerry Lee, statistician at the Duke University, has taken data bank of the Duke University, 1,073 consecutive medically treated coronary artery patients were randomized into 2 groups. And they were comparable, of course, it's a computer randomization. And then he has made another group of 397 patients with a 3-vessel disease and abnormal left ventricular contraction. 3 subgroups. And then what he has found, that these 2 groups, which had absolutely no difference whatsoever, they were the same patients, but just the fact that the computer made 2 groups of them, he found a statistic difference with the treatment A and B, although there was no treatment A and B, showing how erroneous results can be if you use a statistic ad infinitum. One thing which I greatly object to the present trials is the use of subgroup. You have heard today Professor Leontiev describing the results of syntax trial, and he described the analysis. He has taken 3 groups, and with a syntax risk factor of 1, 2, and 3, they made 5 different endpoints. And then they analyzed diabetes and no diabetes. If you multiply this, you will have exactly 30 different groups, which are made here. Now, looking at this, it is a statistical, this is by the statistician. When you have analysis, more and more analysis you perform, the higher is probability that you will find a difference where none exists. So when you're using in a syntax trial, which you heard, when you use 30 different groups, you will have close to 80% probability that the difference will be found in statistics at the statistical level of 0.05, where no difference whatsoever exists between these groups. The next problem with the guidelines, which was also shown in one of the previous papers by Professor Taggart, is that the previous guidelines, European Society of Cardiology 2004, American College of Cardiology, Medical and Heart Association 2005, and British Cardiac Society, they all used very few surgeons. This one had 46 cardiologists and 1 surgeon. on the writing committee. This one had 23 versus 2, and the British Cardiac Society had 8 cardiologists and only 1 surgeon in writing of the guidelines. And this slide you have seen already from Professor Tagat's talk. This is taken from his paper. It shows that in this study, which he analyzed, ejection fraction of more than 50% was found in 100% of the patients, and only 35% had a 3-vessel disease. Now, when you look at your own material, which you treat every day, none of them has a normal ejection fraction, and all of them have a 3-vessel disease. So again, they are not representative. Then coming back to Syntax trial, which made a major noise in the science and in the press, this was published in the New England Journal as a leading journal. I have grave doubts. This said the study had an all-comers design. So everybody who entered the hospital was randomized. That is the statement which stands in this paper. When you look at the analysis, you cannot read all this, but it's 4,300 patients were eligible and 1,800 underwent randomization. And then they start making subgroups. When you make a simple mathematics, where there were 85 centers for 2 years, they were able to recruit only 11 patients per year with a 3-vessel disease and left main. Now I ask you what kind of a center it is which encounters 11 patients per year with a diffuse coronary artery disease. But we have to believe that they are using all-comers design. Every patient has to be randomized. This low incidence is really a sign of the most stringent patient selection for this trial, and that is why we have to take results with after careful selection. Using the second biggest drawback of this trial is unequal treatment in the group which received percutaneous dilatation and a coronary artery bypass grafting. They had totally different drug regime. Using a modern platelet inhibitors was given in 97% of the patients with a PCI and less than 20% of the patients with the coronary artery bypass grafting. So when you look at this, any platelet drug at discharge was in 97% with the PCI and only 23% of the coronary artery bypass grafting. So a study which has a radically different drug treatment protocols in 2 arms of the trial is for me statistically invalid. It should not be accepted, and I'm surprised that the New England Journal immediately accepted this paper. And furthermore, the Syntax trial has been designed by a steering committee in collaboration with the sponsor, Boston Scientific, which sponsors now also the next trial, Excel trial. Now, one must be careful when there is an industry sponsorship of the trials. This was analyzed in Journal of American Medical Association in 2006, and they have analyzed trials made coming from the non-profit institution, the trials which had a mixed financing, and trials in red which were supported by the industry. And it shows that the percentage of positive findings rises the more industry supports. For instance, if you look at the devices trial, the trial supported by the industry had 82% positive results in the trials, and only 50% were positive when they were done by an independent institution. This is one of the classical example of this. This is the class 2A indication for the use of a implantable defibrillator, extremely expensive device, but it should be used, and according to this classification, patient with a left ventricular ejection fraction of less than or equal to 30% at least 1 month after infarction. But when you go to the last page of this paper, then you have to look at the committee, and they have to declare their conflict of interest. Then you will find out that only 5 members of this committee were free of industrial interest. The rest was either consultant or paid, received grants or whatsoever. Again, one questions the quality if there is a considerable conflict of interest. Then you should read carefully conflict of interest. This is completely different. European Society of Cardiology, European Association of Cardiothoracic Surgery guidelines on cardiorevascularization has been written first time by the cardiologist, invasive cardiologist, and by cardiovascular surgeons. And then they decided that you should use the heart team. But for me, these guidelines, which I will show you later, come very much in favor of coronary surgery, is that majority of PCI, of coronary stenting, are carried out during coronary catheterization. They are called ad hoc PCI, and the surgeon obviously cannot be consulted. You cannot get at 9 o'clock, you cannot go to the catheter lab to be consulted about the case. You are busy with your own cases. This ad hoc has been defined strictly, but it is, for me, it is impossible to assemble a cardiac team during catheterization. There is no time for discussion. On the other hand, it is really ethically objectionable. You cannot take the catheters out, take the patient to the ward, discuss it with him, and do tomorrow again a dilatation if you decided to do this. They have guidelines where the ad hoc should be used. The medical management is somehow forgotten, and even today in the less developed countries it is used much less. And previously it was a mainstay of the treatment of the coronary artery disease. The COURAGE trial, which Professor Taggart has also addressed, shows no difference in death or non-fatal heart attack in the angioplasty and stenting versus medical therapy. The optimal medical therapy finds a place in common guidelines, European Society of Cardiology, EACTS. And the recommendation for decision marking in green are shown that recommended the patients be adequately informed of the potential benefits. If you do a large proportion ad hoc, they are obviously not adequately informed. But there is a major surprise in these guidelines. When you look at the summary, you will see that it comes in green that the most of the clinical conditions come in favor of coronary artery bypass grafting, the only exception being 1 or 2 vessel disease with a non-proximal LAD. And this is even a 2B, very weak recommendation. That is what is given in yellow. That was for me a surprise. And then it is excellent guidelines about the simultaneous use of carotid disease, when to use it in valve surgery. And this is from the Professor Taggart's, that obvious argument, these guidelines have been conceived in the best interest of the patients. Now, the question arises, are these guidelines being followed? Because the strict application of the guidelines would massively reduce the number of PCIs. And this fact would have a major financial impact on the hospitals. In many countries, there is no sign that this evidence, that these guidelines are being followed. In the United States, when you look, the number of coronary artery bypass grafting per million population has been declining steadily and continues to decline. In Switzerland, to this data I have from Professor Carroll, it shows a 30% reduction of operative revascularization and only 20 being off-pump. This trend is in other countries as well. This paper was presented in Toronto at the American Association of Thoracic Surgery. It comes from the St. George Hospital in the United Kingdom, and they measured how these guidelines are followed, how the treatment of the patient with the coronary artery disease is handled before and after the guidelines have been published. And they found that practically no change has taken place. Dr. Hannan has asked the same question. This paper was recently published in initial clinical practice, which it was also by Professor Taggart's talk. If the patient has an acknowledged indication of coronary artery bypass grafting, he will get PCI in 43% and coronary artery bypass grafting in only 43% after using these guidelines. Professor Kramer, chief of cardiac surgery in Kiel in Germany, has asked all German cardiac centers, more than 90 of them, he has asked them, is there a standard procedure for dealing with ad hoc PCI? When the patient is in the cath lab and something is found, is there a standard procedure what can be done if the PCI can be done immediately and stenting? 92% said no, they have no standard procedure. Is a heart team established in cardiac centers? 87% of German heart surgery centers have no heart team. Decision is left to the cardiologist. One explanation, which was not in Professor Taggart's paper, but for me it's at least an indicator. In the countries where cardiologists are paid for each PCI, there is much higher proportion, for instance, in France, in Italy, and in Belgium, than in the countries where the cardiologists are paid just a salary, Denmark, in Norway, in Sweden. The incidence is lower if the cardiologist's income is independent of PCI. And this in part explains the huge differences in the revascularization rates between United Kingdom and America, California, New York, Massachusetts. Much higher proportion of PCI versus about the same number of coronary artery bypass grafting per 100,000 inhabitants. And when you look at this, there is an interactive map. You can use it on your computer and find this will be finding a huge differences in the use of stents in America. There are some in here is the insufficient data, and here are the low use, and some of them have the very high use. It's completely incomprehensible why there are such huge differences in the stenting in the relatively homogeneous population, let's say, in northeastern United States or northwestern United States. And this was also shown by Professor Taggart in Organization European Economic Cooperation and Development. You have the huge differences in the proportion of patients which get a coronary PCI treatment, stenting versus surgical revascularization. It leads to some idiotic situations. This was published in Journal of American College of Cardiology, a heart with 67 stents. One patient had 67 stents inside. Of course, he received a pacemaker and everything which belongs to that. Sometimes the authors write, patients have so many stents that later bypass surgery becomes impossible, and that is called full metal jacket by the residents. This I took from New York Times. They discovered a fact that a doctor in Florida has inserted 30 of the company stents into patients during one single day in August 2008, which is a lot of work. 2 days later, Abbott sales representative spent more than $2,000 to buy a whole small-smoked pig and other things for a barbecue dinner. And this is the end, this is the pig being delivered to the cardiologist. In the United States, lawyers are discovering a new profit area, stent lawsuits. You can find this, I copied it from in an airline magazine. If you have a heart stent problems, if a medicated heart stent problems could lead to an increased risk of a potentially fatal broadcast, lawsuits are reviewed nationwide. Request a free consultation, not with a doctor, with a lawyer. And this is completely ununderstandable when you're given this excellent analysis which shows definitely a long-term survival advantage of coronary artery bypass grafting, and I fully support Professor Taggart's statement that the results should not be analyzed after 1 year. They should be analyzed after 3 to 5 years. And this is already has been shown that 40% of all PCIs are considered inappropriate or uncertain. This is the appropriateness score. As a result of this paper, American College of Cardiology has banished the use of inappropriate. It is not called inappropriate now, and they recommend the use of rarely appropriate. And the patients, where it is not clear what to do it, the new phrase is not uncertain, it is now may be appropriate. This official recommendation by American College of Cardiology, in spite of all this meta-analysis showing advantage of coronary artery bypass grafting. For me, the two internal memory arteries, it's one of my patients, which is now about 25 years ago. It shows excellent long-term results with a little or no distal progression. And this has been a paper which many people have missed in the Annals of Thoracic Surgery in 2012. The estimated distal progression rate, if you have a saphenous vein graft, you will have an incidence of distal progression close to 50% after 10 years. A radial artery and left internal thoracic artery will have around 5% distal progression. And there is no doubt that classic coronary artery bypass grafting is a big procedure, it's a big incision, and it ends up with a scar. And it is very adaptable for patients. It looks very attractive, which they have just 2 points in the groin. So one of the most prominent European cardiologists is using often his slides. It is not a question if invasive cardiologists will replace the coronary surgeon, but only when. He is still using it now. And that is a funny paper, which is it'll be impossible for our translators to translate this. Oculostenotic reflex, oculostenotic meaning the narrow eyes, which see only a coronary stenosis, and iatrogenosis fulminans. Iatrogenosis, when you look at the Webster dictionary, it is an inadvertent adverse effect or complication resulting from medical treatment. So this is nowadays fulminating. To summarize and to finish this talk, this is a statement which appeared in a Wall Street Journal, and I could trace it to the literature, goes to Norton Hadler, professor of medicine in Chapel Hill. Stenting belongs to one of the bleakest chapters in the history of Western medicine. Cardiologists are marching on because the interventional cardiology industry has a cash flow comparable to gross domestic product of many countries and doesn't want to lose it. Thank you for your attention.
Dr. Turina, excellent talk, and it really does sum up many of the problems of randomized trials and the conflicts of interest of practitioners. So how do you think, if you could solve this, what would you do? How do you think we should try and solve it?
I still think that cohort studies coming from reputable institutions give us much stronger statement than grouping together some studies coming from institutions with very questionable results, which is now happening in all this prospective randomized study. Second thing, prospective randomized study, and you touched this problem, they are becoming really too expensive. The syntax study, where I am still on the data monitoring committee, we still meet from time to time, has cost now more as $100 million, and Excel trial is going the same direction, and that is why we had to stop meeting. Now we are having only telephone conferences, the data monitoring, because it's too expensive to meet anywhere. So I think prospective cohort studies would be the solution to the problem.
Dr. Cox?
Yeah, I would like to say 2 things. One is that's one of the most interesting talks I've heard in years. And 2, I could not agree more with what the 2 of you have said about prospective randomized trials. I was just in Edinburgh about 2 months ago, and there's been a rumor for the last 18 months that the NICE studies by the UK, or the guidelines, would recommend no longer funding catheter ablation for long-standing persistent AF. And I know the person who's actually in charge of that, the cardiologist, is an old friend of mine. And he gave a very nice talk at the meeting, and that's not going to happen apparently. But at the very beginning, his first statement was, we only used prospective randomized trials to make our recommendations for this for these guidelines. We found 17 prospective randomized trials. So at the end of his talk, we had a rather a rather intense discussion about prospective randomized trials versus cohort studies and so on. And I had not realized, I think until that point, that the problem, what I view as the problem of prospective randomized trials being the only legitimate data, had reached the extent it has in Europe, because it's been that way in the States for a long time. You may as well, you're almost wasting your time if you go to the FDA to get something approved if it's not a prospective randomized trial. My feeling is that prospective randomized trials are really good for medicine, for drugs, for studying drugs, because you can study a drug and a placebo. There's not much way you can mess that up. But you know, in certain studies like the STOP AF or CURE AF, whatever it was, one of the trials somebody mentioned here a couple of days ago, I know for a fact that there was one group in that study that had 0% success. And there was another group in that study that had 100% success. That's not randomization. You know, I think a lot of these prospective randomized trials are doomed from the way they're set up at the initial meeting. And the way I describe it is that you ask the question, does a blue M&M, everybody knows what M&Ms are, right? So does a blue M&M raise your blood sugar? So you go to 15 places and give them a whole handful of M&Ms. The blood sugar raises, and then now you're trying to prove to me that it's the blue one that did it. I mean, there's some of these trials, even though they fit the criteria for RCTs or randomized controlled trials, are anything but randomized and anything but controlled. Mm-hmm. And I think my final point is that our emphasis on prospective randomized trials inherently denigrates the value of basic science that lies behind most of what we've done in the past 100 years or so. As a good example, I don't think we need to have a randomized trial on whether insulin is good to treat diabetes. And I think in most instances, that's the case. But now we're in this era of cardiology essentially, sorry for all the cardiologists here, but cardiology essentially become a specialty of nothing but prospective randomized trials. And I just wanted to say that I completely concur and support your concern about that trend. Thank you.
Thank you. Any other questions for Dr. Turina?
I can add one comment. There is one single surgical prospective randomized study which is double-blinded. It was done about 20 years ago by Alejandro Ares in Barcelona. He examined if the short sternal incision or the full sternal incision for aortic valve replacement brings benefit, the minimal invasive disease. How he did it is, the people, of course, in the operating knew what was happening, but the people treating afterwards did not know what the patient had, because they covered the incision, they put a lot of blood everywhere on it, so the staff in the intensive care unit, the anesthesiologists who were treating patients in intensive care unit and the nurses on the ward did not know if he had a long or short incision until 7th day when they took the off. Of course, there was no difference in the use of analgesic drugs, length of intubation, length of stay in the intensive care unit. This is the only time I know that a double-blind study succeeded in cardiac surgery.